Hi, welcome back to Rohrich Knows Podcast, helping you become a better you and a more educated you. Well, as all of you know, I'm a big advocate of education, but also of safety, especially in neuromodulators and fillers. And I was entranced when I ran across Dr. Farrell's Instagram, because I would see her and she'd be drawing on herself and showing exactly where she was injecting. So I called her, and here she is. So Bita, welcome. How are you?
Thank you. Hi, Rod. Hi, everyone. Thanks so much for having me.
Great. Now, Bita is very unique. She's a board-certified anesthesiologist. She was at UCLA as an anesthesiologist for 20 years, right? And then she's an expert in ultrasound. So she's also an aesthetic physician. So she's used the power of her knowledge of not only as a physician, but as an ultrasound expert to really enhance safety of neuromodulators and fillers. And that's what we're going to talk about today. So tell us about ultrasound and why is that so important today, especially in the face, which is I've written the book on danger zones, and the whole face is a danger zone. Don't you agree?
I agree. Landmines everywhere. Yeah.
Right.
Yeah. So, like you said, my background is as an anesthesiologist, and we incorporated ultrasound into the field of anesthesia to guide us with nerve blocks. With nerve blocks, we're injecting, up to 30 mLs of, Marcaine or something that, if it went into the wrong place or into a blood vessel, it could cause, cardiac arrest. So we incorporated ultrasound for safety and precision. And as my aesthetic practice grew, I kept thinking, why don't we use it in the face? And why don't we use it in the face? Because if neuromodulator goes into a blood vessel, it's not the end of the world. But if filler goes into an artery, it can be very catastrophic. And it can really be disfiguring or even cause blindness. So, and just for myself to sleep better at night and for my patient's safety, I just started using ultrasound in my practice, and now it's become my little accessory and just goes everywhere with me. So
now, just to clarify, now this is an ultra amazing ultrasound device, and you can get the portable ones, which aren't quite as resolution intensive, right? This is a phenomenal device that really is world class, and we're going to demonstrate it as well, right?
Right. This is high definition, high frequency, meaning it gives, especially for superficial structures, it gives incredible detail to where things are. And if you think about it, the arteries of the face are maybe have a diameter of maybe 1 millimeter or a little bit more, and versus something in the body like the femoral artery. So the handheld ones don't give us much resolution. They're still good, but this is one that does not need Wi-Fi, and you just have a handpiece. And yes, it's hospital grade, and you can see everything under the skin.
That's right. It's the Tesla or the Mercedes. That's right. So what we're going to do is we're going to talk and show some areas that are fairly sophisticated to get good results in. And we're going to talk about the DAO, which is the muscle that actually helps you smile or not smile, and its interrelationships with the deeper muscle that actually, if you miss the DAO, you can cause some lip asymmetry. And then the masseter, the strongest muscle of the human body per cubic millimeter, and then the glabellar area. So Bita, why don't you show us how you would do that, and you're going to demonstrate this on yourself and show us the muscles. Yeah.
Sure. I'm going to go ahead and turn off the lights.
Yep, turn off the lights. Okay. That's great. And while she's doing that, I just want to ask you, Bita, so you do this on an everyday basis, right? This is what you use on your neuromodulators and fillers.
Yeah, especially for, masseters, and the DAO, DLI. And for the corrugators, if somebody has had, a permanent eyebrow, like microblading, or if they've had a forehead lift where the position of their muscles could be altered, then I for sure use this just to make sure where those corrugators are now, or, because if somebody has had their brows tattooed in here, it doesn't necessarily mean that the corrugators run underneath it. It could be somewhere else.
That's right.
And, so I'm going to, I use it almost every day, especially in, a certain select group of people. So I'm going to go ahead and start with up here with the corrugators.
Okay.
As you know, with the corrugators, the corrugator and the frontalis are in very close proximity. And if you miss the corrugator and instead get the frontalis, then instead of causing a brow lift, you're going to drop them or even make them look like that Angry Bird cartoon character. So, or whatever it is, video game. So what I do is I put the ultrasound right here, right on top of the brow. And on ultrasound, you can think of gray, white, and black.
Right.
Very white, shiny structures are bone. That's when the sound wave hits the structure, comes back, and gives a very bright image. And then muscles, and then the opposite are fluid-filled structures like blood vessels and arteries, blood vessels, or even cysts, or, they come up as hypoechoic or dark. So, and then everything else is in between. So the muscle is just above it. So I'm going to put it over here, and I'm going to look, I don't know if you guys can see. Let me just put, just going to see where it is on here. So I've got it on right where my corrugator inserts, and we're going to get a couple of muscles here. We're going to get the corrugator and the inner portion of the orbicularis oculi. So the muscle, you can actually see the striations right there.
Right.
And you can see me trying to contract trying to frown, and you can see the muscle coming in.
Right. That's it. That's
it's a very shallow muscle, but.
Yep. I can see that. It's
moving.
It's puckering
up. And then if I come over here, and if I'm on the frontalis, when I'm doing that, you don't see it moving. So this is a way I can gauge and see
where you are and where you're going to inject.
This is, and when I'm on the frontalis, when I'm on the frontalis, when I'm trying to frown, you don't see it, but when I come right on the corrugator, you can see it moving.
It's beautiful. Beautiful. Yeah. Yep. I can see it. You can see it moving.
And you even see the muscle contracting and pulling in this way.
Right.
And then, so this is one area. And again, I'll be honest, I save this for when somebody's had a brow lift, or it's very hard to see where they're, with the tattooing and such, it's hard to see where their corrugators are. The next is moving down, and you mentioned the DLI versus the DAO. Again, a lot of times when the DAO is injected, people inadvertently go a little bit anterior and get into the DLI. And as you know, the DAO makes us look sad, and then the DLI makes smiles and pulls the bottom lip down. So I'm going to show you the two differences. So if I put it over here, this is the muscle belly. When I look at it.
Yep. Right. They're almost fused.
This is the muscle belly. So you can see my teeth underneath talking, but this is one and this is the other. So look at one when I try and frown.
Right.
And then now when I try and smile.
Awesome.
Look at that. That's my DLI. And then this is my frowning muscle that's above it. So they're on top of each other. And when you're lower in the face, when you're more caudal, they are on top of each other. But when you come more cephalad towards the corner of the mouth, they come next to each other. So now they're butting heads. Like.
Yep. So it's very, very hard to inject it there. That's neat.
Yeah,
show us on the mandibular border, on the border. Yeah, that's great.
On the border, yeah. Now you can see there. Then they become much thinner, and they're kind of two sheets on top of each other, and there's the DAO and there's the DLI. So I'm going to go ahead and look sad. There's a DAO. You can really see it contracts and opens up.
Yep, it's further lateral and more superficial. Yeah, and that's usually where I inject. Are you saying I should inject higher?
Well, and then the DLI, if I come a little bit more medial, there's our DLI.
Right, and they overlie each other. That's right.
Yeah. So a good place to inject it is right I always go like 1 centimeter over and 1 centimeter down, and that's a very
Safe.
general way to say it, but that would be right around here. And you can see there they are. There's the two bellies. Do you see them?
Right, and they're separated further.
DL and DLI.
Right. That's interesting.
Yeah, they're separated further. Whereas when you come low, they're really on top of each other, and they're very thin, and the neuromodulator could spread easily.
Right. That's a very good
When
point.
you come higher up, you see now they're higher up. They're more separated.
Right.
There's actually
So it's a finger breath of.
there's a DLI and DAO.
Excellent. Excellent.
And
Right.
you can see my teeth.
Wow. God, I'm learning something here. That's great. That's amazing. And so it's in the mid portion.
So-
Finger breath over and finger breath down. Okay, safety. That's great.
Yeah.
Okay, so let's do the masseter. So I
So
learned
the
something.
Good. As you know, the masseter has two bellies, the superficial and the deep belly.
Yes.
And we've all learned that you need a long needle to get into the deep belly, and it's separated by that deep inferior tendon. And that's something we can see on and I always tell people when you're injecting the masseter, I always use the antigonial notch as my anterior border. And, it's hard to tell people where the posterior border is, but when you go lateral, you could get into the parotid gland.
Right.
And that's something you can see with ultrasound. Again, if I start very lateral, the parotid gland, you can see is right there. You see the little, and if
Right.
I come anterior, there's my masseter muscle.
Right.
I'm going to put it right in the center of the screen. There's a superficial belly, and there's a deep belly, and there's a deep inferior tendon.
Right.
And I'm going to go ahead and clench my teeth. This is a strong muscle. Watch the screen.
Right. And look how that, and do you inject it when you have them bite down?
No, it's more painful that way. When they're, I just do it when they're relaxed. I have them bite down. Look at me when I bite down. Look how the muscle. Do you see that?
Yeah. I mean, I've done it both.
And then you even see the tendon in between.
Right. I've done it both ways. I mean, sometimes when I do the posterior injection, which is right where you are, I have them bite down because then you can inject deep and superficial. And boy, it's incredibly prominent. Look how strong that muscle is. It's the strongest muscle in the human body per millimeter. I mean, because it's that's awesome, and I can see that the boundary between the superficial and deep. You can see it right there. Yeah. So that's posterior, then anterior, and then. So tell us some of the pitfalls here, because if you inject too superficial, you can posteriorly get the parotid, and then you can get the rhizorius anteriorly, right?
Right. So actually, if you go behind, you get to the parotid. If you go in front, you get the rhizorius. And if you don't go deep enough, you're going to miss that big belly. And people are still going to have, still going to grind. And if you don't get the superficial belly, then people get that fish gill. Have you ever had people come
the
back
walnut?
with like a bulge?
Yeah, the walnut. Yes.
The walnut.
That's walnut. That's why when you inject the posterior part, you inject deep, and then you got to inject a little superficial. Yep.
Exactly. So
It's an art.
there.
Yeah. Oh, I love it.
Really?
And this is such a powerful injection for bruxism, facial shaping, TMJ. It's a game changer. I personally think it's as important as the glabellar area. It's a game changer. I love that.
I agree. And I'm a teeth grinder, so it's done wonders for me as well. It's such a wonderful treatment. It's such a wonderful treatment. So, so those are the three areas I use a lot for, because like I said, those are the areas that we often get, complications when instead of the DAO, you get the DLI, or instead of the corrugator, you get the frontalis. Or with this is when you get an incomplete injection, or you altogether miss it and get into the parotid and give them a dry mouth.
Right. And I think that's
a dry mouth. So
yeah, I think it's great. So tell the audience I can tell you what I've learned. I've learned that really the DAO is better to inject in the mid portion, one finger breath over and down. I usually go right on the mandibular. I go right on the border, and I go right where the frown line is. But I think you're right, because it's further separated up high in the mid portion, and it's superficial there. So.
yeah.
I like
Yeah,
that.
I inject it like usually 1 centimeter or 1 centimeter down, and I find that I used to come way down on the mandibular border, and I just didn't. It didn't give them that.
Look.
It didn't give the results I wanted. They could still contract the
Okay.
by the mouth. They could still contract their muscle. So I injected just middle of the muscle belly, but I also give them a little supplement down here because I feel like the platysma sometimes
Right.
attaches there and pulls down too, and also just to make sure you knock out all those muscles that are pulling the corner of the mouth down. So
Right. And that's superficial, of
yeah.
course. Yeah. And then show us with that. I know you don't have the needle there, but show us where you would inject on your masseter. Show us where you would inject your masseter.
So how I always mark the patient is I feel for the antegonial notch, that's
Right.
the concavity along the mandible where the vessels and nerves exit, and I mark that, and I come up, and I just then go over to the tragus, like the ear. So I usually mark this out. Can you see that on my face?
Perfect. Yeah.
So I usually mark that on my face, and I always keep my finger I keep my thumb or right on the antegonial notch, because that tells me the border, the anterior border of the masseter muscle. I don't want to go in front of it because I could get into the rhizorus and affect their smile. So I come here, and then I have them, and I put another finger up at the top, and I have them clench. I have them clench a few times, and then I kind of see exactly where the muscle belly is. And I check with this too. And then when I inject, you just go perpendicular all the way down, and you when you feel it, when you go through that septum, you feel the crunch. You go through it, and I deposit some there, and then I come out, or I go in, deposit some, and then crunch through. Then I know I've got the 2 muscle bellies.
Yep.
And I usually just give like 2 or 3 injection points, superficial and deep, just to make sure I've covered it all. But I put the bulk of the neuromodulator in the deep belly.
Yeah, same here. And for the first time, sometimes I do 25 units per side. three points. But no, it's great. Use a long needle.
Same.
Yeah. So in closing, show us how you would inject your own glabellar area. And I think the other thing is the misnomer of the 5-point injection. I think that is such a misnomer.
Like you said, there's a 5-point injection, and I see a lot of people drawing a V on themselves.
Right.
And injecting the V, and the corrugator muscle, and you can see this, and you've seen this in surgery or in cadaveric dissections. The corrugator, even though we think it goes up like this, corrugator actually is it's very flat. It's just under the natural brows. It just sits right on the brows. So if you're injecting, you would. I'm going to just get a mirror.
Yep. The key is going low.
And staying low. Now, I always use the mid pupillary line, and staying medial to that, and staying. So the head of the corrugator is deep. So I would inject deep right in here into the procerus, and then I would deep into the procerus, and then I would inject deep into the head of the corrugator, because you want to get the head of the corrugator and also the fibers of the orbicularis oculi, because if you get the corrugator but you don't get the orbicularis oculi or the supercilii, they're still going to contract in and down.
Yep.
And then when it comes to the tail, it's very, very superficial. You want to stay superficial with the tail, and you want to point your needle medial, because if you go deep or lateral, you could get into the levator palpebral. And you could cause a droop.
Right.
So and I just think it's very important to stay very, very, close to the brow. And again, like if they've had surgery or if they've had brow augmentation with tattoos, then, you really have to have them contract their muscle. I feel their muscle bellies, and you see you can see a lot the insertion point of the tail, and it's very superficial. You can see it pulling the skin above it. So instead of just following an algorithm of a V or a 5, just really each patient's very, very unique. Just seeing where just a lot, you can see a lot with just them moving it and putting your fingers on them, seeing where the muscle belly inserts.
Yep, it's amazing. Incredible education, incredible thoughts about safety and technique. Fantastic, Bita. Fantastic. So
Thank you.
give us your comments and thoughts. Know before you go, find a highly skilled injector like Dr. Farrell, who's amazing. She's and follow her on Instagram. It's fascinating and very educational. So thank you so much, Bita. And this is part 1, and part 2 will be talking about filler safety. See you next time.